Welcome. I'm Annette Pompa from the International Heart Spasms Alliance, a fully vetted nonprofit organization. Our general aim is information regarding angina with non-obstructive coronary arteries. In this info share, it's about sex differences in microvascular disease parameters with Dr. Michel Corban from the University of Arizona. Patients with small vessel disease or microvascular angina with NOCAD have open larger vessels, but their microvessels are not dilating properly. This means they are at an increased risk for major cardiovascular events such as stroke, heart attack, and even death. Women were thought to have more of an increased risk towards microvascular issues, and still are. However, we cannot forget our heart brothers. The percentages between men and women are not as starkly different as once believed. Recent research in gold standard invasive testing suggests possible misdiagnosis and underdiagnosis of male patients. Sex-specific differences in coronary physiology and diagnostic coronary flow reserve testing algorithms for women and men need to be highlighted. We must not think that women so far outweigh the men in these issues that then we miss the men or falsely reassure them. On this topic of sex differences, there will be a part 2 to follow. It's going to focus on 2 male patients sharing their experiences. It's an important follow-up about the very real issues patients have in achieving a diagnosis and best management. Thank you for watching the shared research and interview with Dr. Corban.
Well, thanks for having me, Annette and Sarah. So today we're going to talk a little bit about the sex-specific CMD parameters. Is it different between men and women? Are men and women equally affected? And why would it be that women or microvascular disease and vasospastic angina are portrayed as a woman's disease, whereas reality is that it's not exclusively a woman's disease. There are a lot of men who are affected. So hopefully I can convince you today and show you the data behind this. And then we'll touch base a little bit about an update on novel cell and device therapies for coronary endothelial dysfunction and so no disclosures related to this topic. Do CED and CMD, and CED is going to be endothelial dysfunction, CMD is microvascular dysfunction, only affect women. So first we need to understand what the big picture is, and what is the prevalence of non-obstructive coronary artery disease in patients undergoing clinically indicated angiography. So this is a data from the NCDR in the United States, which actually shows that between 2004 and 2008, among all patients that came to the cath lab for clinically indicated angiogram, which means either they had typical angina or they had a positive stress test for ischemia, and they had no known CAD prior to this, 40 to 59% had non-obstructive coronary artery disease. So just imagine how many angiograms we do every day in the United States, in the UK, in Australia, in all these different parts of the world. So half of these angiograms will be negative for obstructive coronary artery disease. The big mistake that we currently do, and this service that we do for our patients, is to stop there. So these 50% of patients that don't have obstructive CAD but have symptoms still have no answers. And that's the real problem that we face today with angina and non-obstructive coronary artery disease. Now, if you look at these graphs, you can see that there is actually more women that have angina with non-obstructive CAD. And you can see that, again, among all comers to the cath lab that have angina or a positive stress test to undergo an angiogram, 1/3 of the men will have non-obstructive CAD, whereas 2/3 of women have non-obstructive CAD. So this is maybe where part of the problem and the portrayal of ischemia or angina and obstructive CAD as a woman's disease comes from, because you have more women that have angina but have no obstructive coronary artery disease compared to men. Now, if we take these 50% that we talked about coming to the cath lab with no obstructive CAD, and we actually further stratify them, if we do the reactivity testing to see, what is the underlying problem and whether they have a problem in the coronary physiology or not, the numbers are actually pretty striking. So among all these patients that come to the cath lab for a reactivity testing, you will have 90% that will have some sort of abnormalities, either microvascular angina, 51%, vasospastic angina, and this is either here it's being referred to as epicardial vasospasm, 17%, or they have the mixed phenotype of epicardial spasm and microvascular dysfunction. This is 21%. So among all these patients, only 11% will be non-cardiac. So it's really, really prevalent. So if you look for it, you'll find it. But if you don't look for it, you're never going to find it. And, we can't see the small vessels. And vasospasm is not always spontaneous when you look at the arteries. So you have to look for it. You have to be proactive. This is a similar data that shows 64% of patients with non-obstructive coronary artery disease have microvascular dysfunction. So is CMD associated with poor prognosis only in women? So now we have established that it's not only a woman's disease. It's both a woman and men's disease, but with a more predilection in the woman population. But the second question that comes to mind is, okay, men are affected. So are they affected equally to women? Or is it only women who have the poor prognosis with microvascular disease? So the data is actually very clear on that. So men are equally affected to women. So you can see here the MACE, the major adverse cardiovascular events, stratified by female versus male. And then these are the patients who have a CFR less than 2 versus males with CFR less than 2. And you can see that the rate of MACE is equally bad in both males and females. And there is really no gender difference. Now, there is a difference whether you have an abnormal CFR. So if you have microvascular disease, you're going to have worse outcomes compared to somebody who has normal CFR. But if you are a male or a female with an abnormal CFR, you're going to have equal badness. And then this is the same thing on the right side panel. And you can also see that the annualized MACE is also, is also abnormal. And it actually affects both males and females when the CFR is actually less than 2. And again, obviously, if you have microvascular disease, you're going to do worse than somebody who has normal CFR, and then women as well. So this brings us to another question now. Are we capturing males and females equally when we do the invasive testing? So, if males are affected and if they have the same adverse outcomes as females, then, why is it so? Why is it portrayed as a woman's disease? Is it that we are underdiagnosing men? Or is it that we are overdiagnosing women? Or is just a mere fact that we don't think about this disease in men? So these are the potential problems as why men have been sidelined with this disease for a long time. So one of the things that we try to do is we try to look at, the hemodynamics between men and women CFR between men and women, all comers, and then determine, whether there are certain parameters that affect our diagnostic tools in the cath lab in terms of men versus women. So the interesting part, and this is what Sarah and I touched a little bit about, the different techniques, but it's not really the different techniques in diagnosis, but it rather the different cutoffs that we use. So if you look at the WISE study, which is the Women's Ischemia Syndrome Evaluation Study, they used the CFR less than 2.24 for diagnosis of CMD. And this was pure women's trial. Now, WISE demonstrated increased risk of MACE in women with chest pain and impaired CFR that is actually less than 2.32, which is not really the cutoff for diagnosis. So it's a different cutoff for MACE. And then the PET studies demonstrated that an impaired CFR with less than 2.0, so you see all these numbers, is a strong predictor of cardiovascular mortality. And then the PET studies demonstrated that the increased risk in MACE in women compared to men is associated with severely impaired CFR less than 1.6. So you see cutoff of 1.6, a cutoff of 2.0, a cutoff of 2.24, so there is really no standardized single cutoff for, what is abnormal CFR and what CFR cutoff is associated with abnormal outcomes. And I think, the truth lies somewhere in the middle. I think that CFR is like is a spectrum. It's like when you talk about heart failure and the ejection fraction of the heart. So the worse your ejection fraction, the worse is your outcomes. And this is basically similar, in my opinion, with CFR. So the worse your CFR is, the lower your CFR is, the worse is your outcome. So clinically, what do we do now? Like, what is our cutoff when we do these clinical trials or clinical assessments in the cath lab? So clinically, in the absence of a hemodynamically significant epicardial disease, a CFR cutoff value of less than 2.5 is currently suggested to be diagnostic of CMD in both men and women. However, this assumes that the resting, which is the denominator of that equation, and the hyperemic, which is the numerator, flow in response to the medication in that CFR equation is similar in men and women. But the real question, is this true? Is the resting flow equal in men and women? And is the maximum flow equal in men and women? If that's the case, then, a cutoff of 2.5 makes perfect sense to diagnose men and women with microvascular disease. So this is, there was, in 2015 came a small study from the United States that showed, was just 117 women and 40 men. They had angina and no obstructive coronary artery disease, and the coronary blood flow was measured by thermal dilution. And what they actually showed is that CFR is actually not the same in men and women. They showed that actually women have a lower CFR compared to men. When they further looked at the flow, and you know that the transit time in thermodilution is actually inversely correlated to the absolute coronary blood flow. So what they looked at is this resting transit time in women compared to men, and the hyperemic flow or the transit time in women compared to men. And what they found is that the resting transit time in women was actually lower than that in men, suggesting that the resting flow in women is actually different than that of men, whereas the hyperemic flow was the same. So the maximally achieved flow was the same. So this actually was very interesting to see. So this was the first time that we have looked a little further into that question about, do men and women have similar flows at rest and maximal flow in response to adenosine, or do they have similar CFRs based on this data? And this was pointing towards no. So then we came and did a much larger study. This was 1,096 women and 587 men. Again, angina and no obstructive coronary artery disease. CFR was measured by Doppler APV, not by thermodilution. And coronary blood flow was calculated using the APV, the velocity, and then the diameter of the artery. And then what you can see is that CFR is indeed lower in women compared to men. The resting coronary blood flow in women is actually higher than that in men. And the hyperemic blood flow is actually lower in women compared to men. So now you are actually looking at a totally different, or you're looking at a significant difference in coronary physiology and flow between men and women at rest, maximal flow with adenosine, and then CFR, which is the ratio of that flow at maximal flow divided by the resting flow. So this is the equation of CFR. So women have a lower CFR, and that's because they have lower hyperemic flow, which we just talked about, and they have higher resting flow. So if you combine a lower hyperemic flow, which is the numerator, and a higher resting flow, which is the denominator, this explains why actually women have lower CFRs compared to men. So this actually brings a different and a more important question now. Is female sex an independent predictor of a lower CFR, lower maximal flow, and higher resting flow? And thus, this is what we found basically, is that the female sex was actually an independent predictor of all these three. And therefore, this challenges the assumption that the resting and the maximal flow in that CFR equation is similar between men and women with chest pain and no obstructive coronary artery disease. Which actually brings us to another question now. If women have a lower CFR than men, and our cutoff is 2.5, that's maybe why we're capturing more women compared to men. So maybe if our cutoff for women and men was different, let's say for women it was 2.5, but for men was 3.0, just, giving an example, then, you're going to be capturing more men with microvascular disease compared to the current number of women that we are capturing based on the current 2.5 cutoff. So this is a true question now that we have from a diagnostic standpoint, is whether, diagnostic CFR cutoff should be sex specific or not. And that's something that we will have to answer with future studies looking at optimal cutoffs that predict outcomes, because that's where, the importance of a cutoff comes in, is whether your cutoff is good enough to predict outcomes, and therefore, clinch diagnosis and start therapy. So this has, as I said, has potential diagnostic implications of, on CFR, on diagnosis of microvascular disease. So coronary microvascular dysfunction is currently widely regarded as a woman's disease, possibly secondary to underdiagnosis of men, where diagnostic cutoff value of CFR might be more than 2.5, and or overdiagnosis of women, where the diagnostic cutoff might actually be well lower than 2.5. Now, the question that comes up next is, should we not use then a flow parameter? Should we use a resistance parameter in order to actually diagnose men and women, and whether this is different between men and women or not? So would a resistance rather than a flow parameter be more suited for a universal CMD diagnosis? And this question is still open to debate, and that's because, in our study, the resting coronary microvascular resistance was actually the same between men and women. And this is similar to what the other smaller study has shown, that there's no difference in the resistance between men and women. So whether resistance is a better parameter than flow for a universal diagnostic cutoff between men and women still remains to be validated. So, a talk on microvascular disease and angina and ischemia with no obstructive CAD is never complete without touching on, the novel cell and device therapies for endothelial and microvascular dysfunction. And that's because that's really what matters most for patients. So patients, maybe they care a little bit about diagnostic cutoffs, but they care much more about how they feel and whether they're having chest pains and whether they're able to lead a good quality of life or not. So cell therapy trials, we have 3. So Escape CMD, Improve CED, and Freedom trial. So first, let's talk a little bit about why cell therapy is important, or what is the promise of cell therapy in microvascular disease. So this is a study, an old study now from 1997, published in Science, where actually the researchers injected human CD34 positive cells, which are the stem cells that are endothelial progenitor cells, into the rats' ischemic limbs. These are native rats. And then you can see that, when they injected the human stem cells, these stem cells, they migrated to the ischemic limbs of these rats and actually started forming new networks of vessels. So this actually brought up the question of whether these cells can actually restore microvascular integrity. So once you have buildup in the microcirculation, you have increased resistance, or you even have obstruction of the microcirculation, whether, new cells that go to ischemic muscle can actually generate new vessels and new network of vessels that can actually keep up with the demand of the heart muscle. So this is the CD34 cells mechanism of action, as I said. So they actually generate what we call neo-revascularization. So it's generation of these new small vessel network when the old network is actually non-functional anymore, either obstructed or occluded or severely narrowed, and the resistance is very high down there. So this was the Escape CMD trial that we and when I was at Mayo and Cedars did this study together, and it was sponsored by Caladrius, which is a cell company. So it was actually focused specifically on CFR. So the entry criteria was microvascular disease with abnormal CFR. So these patients were actually enrolled in the study. It was an all-comer study, single arm. We mobilized the patient's own CD34 cells from their bone marrow. So we gave them medications to actually push these cells out of the bone marrow into the circulating blood. Then we actually collected these CD34 cells and then re-injected them into the coronary arteries. And what we've seen is that injecting these endothelial cells into the coronary arteries actually improved coronary flow reserve in this patient population at 6-month follow-up. And it actually improved the angina class, in addition to improving the Seattle Angina Questionnaire parameters across the board. So this was the first trial showing that stem cell therapy for CFR abnormality can actually improve CFR, which actually is a big finding, because up until now, all the medications that we have will actually not improve CFR, but improve symptoms. So now we have possible medications that can actually improve both symptoms and actual CFR number, which means microvascular function. And then came our trial, which was parallel to the first one, and this was the Improve SED trial, which we did at Mayo. And then again, the Improve SED trial, which was an intracoronary autologous CD34 positive cell therapy for microvascular endothelial dysfunction. So the first study was CFR abnormalities. Now here it's endothelial dysfunction. So whether you have spasm in the big vessels or whether you have spasm in the small vessels, this is the entry criteria, regardless of your CFR in this study. And what we have shown is that doing the same thing, mobilizing the stem cells from the bone marrow into the blood, and then collecting them and injecting them back into the coronary arteries, this led to improvement in microvascular endothelial function, improvement in Seattle Angina Questionnaire and quality of life scores, and improvement in CCS angina, in addition to nitroglycerin use per day. And then came the Freedom trial, which was a big disappointment recently. The Freedom trial was a randomized control trial, which was actually a pivotal trial for stem cells, based on the very encouraging results of ESCAPE CMD and Improve SED trials. And this was a randomized control trial to taking all comers with angina and or ischemia with no obstructive CAD. So whether your CFR is abnormal or whether you have endothelial dysfunction and vasospasm, and then doing the same thing, randomizing them to cell therapy, intracoronary cell therapy, following them up for 6 months, and then looking at the change in angina, CCS, and all that. So unfortunately, it was stopped prematurely by the sponsor in June of this year because of slow enrollment and inability to sustain funding for a longer period of time for this trial. So the data is there, the prelim data is there, but unfortunately, we don't have an ongoing trial to test it in a bigger scheme. So probably this will come back, with a bigger trial, but this is on hold. Cell therapy research in a randomized trial is on hold at this point until a new trial starts. And then we have the device trials, which is the coronary sinus reducer, which is an hourglass-shaped device which we place in the coronary sinus in order to reduce the coronary sinus and therefore increase the backflow or the back pressure into the venous system, forcing that blood into the microcirculation that has high resistance, where the myocardium is ischemic. So if you can push more blood into that myocardium, then you can actually potentially improve ischemia and symptoms. So this is actually the coronary sinus reducer trial that we started at Mayo. It's actually on the verge of complete enrollment at this point. It's 30 patients being enrolled with CFR less than 2.5 or HMR more than 2.5. And then putting in the reducer trial, the reducer system, which is the reducer device in the coronary sinus, following them up for 4 months, and then bring them back for evaluation of CFR, HMR measurements, in addition to the angina, Seattle Angina Questionnaire, and the anti-anginal medications. So in addition to a stress test that we're doing at baseline follow-up to look at ischemia as well. So you can see, this is another trial that is now looking into novel therapies for microvascular dysfunction. So hopefully we will get some more data in the near future from this trial, and then maybe that would be another avenue for patients with angina and or ischemia who remain refractory to our current medical therapy. Now, based on this trial and other data from Israel, there's actually a new trial called COSIRA-2 trial in the United States. That is for obstructive CAD with no revasc options. But based on the data that we have so far, there is actually a single arm in that study that's going to start looking at putting that reducer in patients with angina, but no obstructive coronary artery disease as part of COSIRA-2, but a single separate arm rather than a randomized trial. So with that, we're gonna end, and we're gonna take some questions if you have some.
I was wondering with the studies that are currently happening or ones in the past. So I noticed that like the numbers of women are so much greater than men that are enrolled. Is that just because it's easier? Like, does that matter? Because it doesn't matter if it's like an equal amount, because you're still
No, it's
seeing
actually it's actually part of the problem that we talked about. So these are people that need to be referred, and if we keep on portraying microvascular and endothelial dysfunction as a woman's disease, referral is going to be lower for men, and therefore less men will be enrolled in microvascular endothelial function studies.
Right. Yeah, it's really difficult to get the appropriate amount for the entire population of men likely affected. Well, we're working on that. We're hoping with all of your information, and we just keep talking about it. I know that we have in our support groups, I just added 3 men this week, in the last couple of days, where I'm seeing at least more of that happen. It must mean that perhaps it's trickling down and more people are recognizing men, which is good. I just know that for our heart brothers that are dealing with all of this, we're very passionate about it being, equal care as we are for everybody. We want to have enough help for the entire population of people dealing with non-obstructive disease. Yeah.
I have a question. Sorry, I have a question too. Sorry, you continue. Answer.
No. I agree. I'm just agreeing.
Okay. Really interesting about the difference between the coronary flow reserve between men and women, because we've got a couple of men at the moment who came in with borderline CFRs 2.6. And what you're saying is, and of course they were told, maybe not, but from your information, it's actually that, yes, they probably may well have a problem. And of course they're going to, and that's really interesting. And the other one I wanted to ask relating to that is, why is the CFR different in women? Is it because women's hearts and the blood vessels are smaller? And if you had a taller woman or a smaller man, would that make a difference? Or is it our hormones?
Well, that's a great question. So let me first answer the first question. So, maybe yes, for men with a CFR 2.6. Maybe the cutoff is not 2.5 for men. Maybe it's higher. So it's maybe no, but maybe yes. And this is exactly why it's important to look into these diagnostic parameters and, look whether there is really a sex-specific different cutoff for men versus women. So that's number one. Number two is, women have, in general, smaller hearts, less muscle mass. They have smaller arteries compared to men. But what's interesting is that when we did that study that was published in Neurointervention, looking at the difference in CFR between men and women and the, baseline resting flow and the hyperemic flow, we actually also adjusted for BSA, which is the body surface area, which is the, closest you can do to, take that into account, between men and women, the difference in muscle mass and all of that. And, we did not see a difference between, the data held when we, indexed by the body surface area between men and women. So women still had, actually still had lower hyperemic, maximal flows and higher resting flows compared to men. And therefore, because that equation has a lower numerator, higher denominator, women ended up having lower CFRs. And that was confirmed when we looked at the CFR of women versus men in all comers. So now the real question is, why do women have slower flow at baseline? I'm sorry, have higher flow at baseline and have lower flow maximal conditions. So that's the real question that we don't have an answer to yet.
And of course, the other question that comes from that is about how the menopause may play a part, and about pregnancies, what's happened in a woman's reproductive history. And is there a role? Isn't that another thing that causes a lot of debate within our community? What is the role of HRT? Is it protective? Is it appropriate? Are there problems? Where does it fit in with caring for us as a group?
Yeah, this is a question that's unsettled. It's still an unmet question. You know, we see a lot of women, and I don't, you know, maybe you can tell me more about this, but we see a lot of women who have pain actually around their menstrual cycle. So there is more pain episodes. They don't feel well around their menstrual cycle. And, you know, this is when there is, you know, hormonal changes and shifts and all of that. To date, we don't have the data to explain this. We see it clinically, but we don't have an answer as to, you know, how is estrogen versus progesterone versus, you know, this balance or imbalance of these during the menstrual cycle help or worsen flow and therefore, you know, pain. But clinically, definitely there is, you know, we do see this, but we don't have the data to explain it yet. And more so is, you know, there is also a very strong correlation between polycystic ovarian syndrome and microvascular disease. So having polycystic ovarian syndrome actually is a risk factor or increases your risk of having microvascular disease. And that's also a hormonal imbalance that, you know, we know that it exists. We know that there's a relationship, but we don't know exactly how the two are linked.
That is absolutely fascinating, because that could relate to somebody's reproductive history, that they had difficulties getting pregnant. Again, the issue about raised blood pressure in pregnancy. So the story continues.
Yeah, not only that, though, we have a paper actually looking at the relationship between endothelial dysfunction and antiphospholipid syndrome and miscarriages during pregnancy. So it's fascinating to see the link between, you know, how thrombus or clots develop in the vessels and the relationship to endothelial dysfunction. So you have to have endothelial dysfunction actually to develop clots with antiphospholipid syndrome. And this is another reason for the miscarriages. And again, as we said, endothelial cells are the same everywhere in the body. So if you have endothelial dysfunction in one organ, then you have endothelial dysfunction in another organ, including the coronary arteries of the heart. So it's definite. There is definite strong correlation between endothelial dysfunction, antiphospholipid syndrome, and clot formation and miscarriages as well.
There's so many things that we see that cross connect, and like you're saying, we've always talked with our members and people we help support, because it's once you're diagnosed with, say, microvascular dysfunction, and I know I personally had a difficult time getting diagnosed, because actually that cardiologist said to me, I don't know, it doesn't make any sense. Why would you have it only in your heart? And who knows why we feel it where we feel it, why it decides to go where it does. And if there's just
because your kidneys don't cause pain.
True.
Or your retina doesn't cause pain, you know, you only feel, you know, the only way you find out that you have a problem in your kidneys is when your kidney function goes down. or your eyesight starts to get worse. So it affects all organs, because the entire vessels of the body are lined by endothelial cells, and they're exposed to the same genetic material. They're actually exposed to the same systemic risk factors. So the heart comes to the attention because it hurts. So when it doesn't get blood, it hurts. Your kidneys don't hurt, but their function goes down.
Right. I know there are some people that were, say, diagnosed first with difficulties with cerebral symptoms and things they were getting, and then the heart started. But yeah, typically it is the heart that we feel first. That makes a lot of sense.
Is it because the heart is more sensitive to a lack of blood supply?
Yeah, and it hurts. So if you don't get enough blood to the heart muscle, it's gonna hurt.
I have another question.
If you don't get enough blood to your kidneys, the kidney function will go down, but you're not gonna get, similar or equivalent ischemic pain in your kidneys.
Do you think the endothelium is the most underrated organ of the body, that it's sort of sitting inside us and we just don't realize how important it is?
Biggest organ of the body.
Well, it's everywhere, isn't it? It's a sort of and it's like the secret. It's involved everywhere, yet we don't realize just how fundamental it is to our well-being and every organ of our body functioning properly.
Correct. It is the biggest organ, and it is the forefront of, exposed to all the risk factors in the circulating blood. So it just makes sense. It just makes sense for it to be, affected widely and affected equally in different organs of the body.
So this is actually a multi-organ condition, but it just presents with pain in the heart.
Absolutely. I mean, I have the slide here, but we wrote an editorial in the European Heart Journal, coining the term of systemic endothelial dysfunction, because it is a systemic disease, but not only affecting the heart but affecting other organs. But again, as we said, it comes to the attention because the heart hurts, and this is where the workup starts.
Well, thank you very much, and thank you very much for obliging me at the beginning with all my questions. We could be there all day. There's so much. It's such a fascinating area, and it's such a privilege for you to give us your time and your patience with us. So thank you very much.
Pleasure. It's an honor to be with you. Thank you.
It's mutual.